Good morning. I'm Dave Christensen. I'm making this video as a student at Grand Canyon University for communication and application of research in practice. So we're going to talk about ethics in healthcare. Um, Ethics is defined by Merriam-Webster as a set of moral principles, a theory or system of moral values. So there's quite a storied past in the ethics in healthcare projects with human subjects, and so I'll go over a few of them. Some of them are really well known, like the Tuskegee Project of 1930 to 1969, which infected black men with syphilis and left them untreated so that they could study the effects. MK Ultra was a government project from 1950 to 1974 with over 150 experiments on people using psychedelic drugs, paralytics, and electroshock therapy. Some of the lesser known ones um, are Leo Stanley, was a doctor at the San Quentin prison who conducted testicular transplants from 1913 to 1951 on prisoners. Chester Southam in the 50s and 60s injected cancer cells into the abdomen of first elderly and people and then prisoners. His theory was so the elderly people, they developed cancer in those spots. And then he switched to prisoners because he thought that they would have a better immune reaction. His study was to research the effects or the immune response to a healthy human body. So Wendell Johnson in 1939 studied 22 orphans who had stutters or speech impediments, and his study was the difference between negative and positive reinforcement on children. And so he ridiculed 22 orphan children in an attempt to cure their stutter. Albert Klingman in 1951 was a doctor who used chemicals on prisoners to study the effects. He worked on behalf of cosmetics companies, and those prisoners were not told about the potential side effects. Carl Heller from 63 to 73 used radiation therapy on the testicles of prisoners in Oregon State Penitentiary to research the effects. He did compensate, so the study did compensate the prisoners, but it raised questions about the coercive factor of financial compensation. And then Jesse Kurzinger, in 1999, he died at age 18 as he was a test subject for gene therapy for OTM, which is a deficiency. It's a metabolic disease that inhibits the disposal of ammonia. He was injected with gene therapy with attenuated cold virus as the carrier. He had a bad immune reaction to the carrier virus, and that resulted in organ failure after only 4 days. So, the major questions surrounding his death involved informed consent. A lawyer retained by his family said that other patients had experienced side effects from the therapy, and 3 monkeys had died. He was not informed of any of this. So, the two ethical issues that we're seeing, which all stem from communication, are informed consent, which is communicating clearly the intent and the process of the study, and then being forthcoming with all of the associated risks. A lot of these test subjects never even gave informed consent because they were never informed that they were even test subjects. And then the others were not informed of all of the potential risks. So those have to do with communication, and communication really is the crux of all of these issues uh, with the ethical or unethical research projects, either by omission or commission, either telling them that something was going to be something that it actually was not, or um, denying them information that would have given them a better opportunity to make a better decision going forward. So, to guide researchers, there's a lot of ethical models published across the internet. To guide ethical researchers, the Behavior Analyst Certification Board in 2020 came out with a list that's defining the issues and the potential risk and those who are could potentially be affected, gathering all of the supporting documentation to confirm that this actually is an ethical concern, considering personal knowledge and personal bias in the context of the affected individuals, identifying the core principle and code of ethics and then applying it to the research process. Consulting available decision making guides like the one from uh, the board, developing contingencies and then evaluating those contingencies to make sure they're even going to have any effect on the potential risks, and then selecting what is most likely to work and applying those contingencies, and then evaluating the outcomes. I'm going to school for physical therapy. That's ultimately the goal. And in the context of how I would use this and communicate effectively with a patient or parents of a minor patient, um, is we would at, at the onset of the study or when recruiting people for the study, have some kind of a group educational type of a session where they would be informed of all the potential risks and given all of the background information, like what what is the purpose of the new whatever intervention that we're trying to test, um, what could be the potential dangers, what mitigating factors we can put in place, and then allow them to ask questions to explore as much information as they need, so that they can make an informed decision and provide consent. And then asking them to help brainstorm mitigations and contingencies that they're comfortable with. Once all the information is on the table, then they can actually provide informed consent. But until they are fully educated on the situation, it's very difficult for them to understand what they're um, applying for. And then the documentation of the event is incredibly important. Um, any relevant notes should be sent to the patients or the families, and then publish the findings as soon as practical for peer review. So remember, when we're doing uh, a research project in healthcare, we are using people. The end does not justify the means, and we need to be empathetic and remember that we take an oath to do no harm. Have a good day.